Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Today, we're going to talk about testing. I have Dr. Taylor Bright with us. Dr. Bright is our Director of Infectious Diseases. Dr. Bright has a degree in molecular biology from Princeton and a PhD in Infectious Diseases and Genomics from UC San Diego. He's heading up our lab. A few updates for you before we jump into this. Just in the last hour, we announced that we're closing the Kentucky Castle to the public. This is not mandated yet, but I would encourage other people with other venues or places like this to potentially lead. Don't just wait for these places to be closed. If you can close down, we believe you should. That's our opinion, but just giving you my opinion. Number two, we're sending testing kits out to our patients today. That's in process. So if you're one of our patients who need to test, it should be coming. We also just received today more of our immunity packs. We put together what we think is the best evidence to boost your immune system with supplements. And so if you had requested one and we were out, let us know and we'll send you one if you're one of our patients. And just to timestamp this is Monday, March 16th, 2 p.m. We've also emergently added several emergency medicine doctors to our team who can take calls. So we're ramping up our telemedicine services even more. We have a large team already, but we're adding to that to take care of you as you're worried in these times. Speaking of that, we just got news of 2 emergency medicine doctors who have passed away from the coronavirus. This is really heartbreaking. And I would say if you're on the front lines and you're treating patients and you haven't listened to our podcast with Scott Weingart, we released that this morning at 7 a.m. And there, I think, are some really good tips on protecting yourself. You have to take care of yourself or you're no good to anyone else. So please take care of yourself. Listen to that podcast. It just came out today for tips on how to do that. Finally, if you're a patient of Wild Health, tune in tomorrow. We're going to be releasing details on all of our testing protocols and exactly what to do. We're dealing with a lot of sick patients, and the less you can call the office and the more you can tune into the Wild Health Podcast and hear about our protocols, the better, the more we'll be able to do for more people. And as you're listening to this podcast, send us questions around testing to @WildHealthMD. Dr. Bright is brilliant in this, and I think potentially one problem we'll have is he understands this so well that some of the things he may talk about may not be super translatable to a layperson who isn't living in this world. So if we talk about things that aren't clear, send us the questions, and we're going to have Dr. Bright back on very frequently for more updates because this is changing so quickly. Luckily, I don't understand this nearly as good as Dr. Bright, so I'll hopefully be able to stop him when it's too complex and slow it down. So, Dr. Bright, I'm going to jump straight in without a lot of chit-chat here because we want to give updates quickly. People have limited time. First off, just maybe describe the testing from a patient's perspective and from a physician's perspective. So if you're a patient and you feel like you want to be tested, what does that look like when you request a test? How is the test done or collected?
So the current CDC recommendation for collecting testing specimens is a nasopharyngeal swab, or an NP swab. And so this is a fairly very simple procedure. A patient could probably perform it on themselves if they're at home, but obviously a medical professional, it's a regular type swab. You kind of see it with influenza or other respiratory viral infections and that you're trying to test for. So basically a swab is inserted into the nostril parallel to the palate, and then is left there for 3 to 4 seconds and then removed. That swab is then placed into a universal transport media to preserve the sample, and then that sample is then shipped off to the testing facility. If you're going to test that sample within 72 hours, you can ship it on cold packs, and you can store it in the fridge. Anything longer, you need to put that at minus 70. So from a collection standpoint, from the patient perspective and from the physician perspective, it's a very simple test to collect the specimen.
So that description was great, but a picture's worth 1,000 words, and a video is worth around 4,375 words based on my last calculation. So we will do a video and post it on Instagram with exactly how to collect, because with our patients, a lot of you are remote, and we're actually sending this to you to collect. So one description I use just to drive the point home is, if you're right-handed, put your left hand on the back of your head, put the swab in until you can feel it tinting the skin on the back of your head, and then you've gone far enough. I'm actually joking. Obviously, you're not going to go through your brain, but it's deeper than you think. So we'll put a video out on how to collect this, because if you don't collect an adequate sample, then you wasted your time and you wasted a very valuable and limited test. So we'll put a video out on exactly how to do that. Dr. Bright, what is the sensitivity and specificity of this test? And to just make that super simple, how accurate is this test? And we'll talk about it in terms of sensitivity and specificity, and we'll try to translate for people what that actually means for how good the test is.
Sure. So full transparency, as this is a dynamic situation, we really have a very limited understanding of the current sensitivity of the test, because the number and types of patients that are currently being tested is quite constrained. We'll get into a minute why testing heretofore has been quite constrained. So sensitivity-wise, we don't have good numbers at the moment. Specificity-wise, so the most recent revision of the CDC COVID-19 diagnostic test was released actually this morning. That'd be the morning of March 16th. And the specificity looks quite good. They've amended the test a little bit since the initial test was released in early February, showing that this test will not have false positives related to other coronaviruses, even from other species, as well as other human pathogens. So from a specificity standpoint, the test looks quite good. From a global, from a public health testing perspective, sometimes when you have too high of a specificity, you are missing some patients, so there is a concern there. But right now, the specificity is quite good, and sensitivity is still kind of up in the air. To Matt's question about accuracy, the idea here is, if you feel you need the test and you receive the test and receive a positive result, you most likely have the SARS-CoV-2 virus, which is the cause of the COVID-19.
Do you have any actual guess? I mean, what numbers have you seen on sensitivity? Can you give us a number or a range, at least with a confidence interval?
So, I mean, if I'm going to put a number out there, the sensitivity in terms of the ability to actually find those individuals who have who have the virus, you're able to detect all of them, is you're going to see it probably, we're north of 50%. So we're able to find those patients if they can get the test. The sensitivity is not the issue right now in terms of finding, in terms of the testing issues. The issue is getting more and more tests to people based off of their different symptoms, and then based off of their contact with other individuals known to have the disease.
So I don't think I understand. I'm asking for some clarification. You said the sensitivity is greater than 50%. I mean, I would hope so. If its sensitivity is 50%, then half the people that are sending the test in that are positive and have the virus would come back as negative. Any guess as to what the actual sensitivity is, or are you just being extremely conservative because you have no data?
So, I mean, at the moment, we're being extremely conservative, again, because we're testing patients where we're fairly certain based off of their clinical symptoms, they are exposed to a respiratory virus, and at this moment, that is the dominant species is this SARS-CoV-2 virus. So at the moment, when individuals come back as negative, when individuals come back as positive, we know they have this virus. When they come back as negative, it seems as if they do not have SARS-CoV-2, but they had symptoms enough to be tested for this particular virus. So at the moment, because of the way the test is run, we just don't have great numbers on what it actually means from a sensitivity standpoint. Do you have another coronavirus? There are 4 or 5 endemic strains depending on where you live. Or were you tested out of an abundance of caution for a flu-like virus, for instance? So sensitivity is just going to take more time and more testing to really zero in on.
To translate a little bit, sensitivity and specificity change with the population that you're testing. What percentage of those patients have it? Positive and negative likelihood ratios do not change. So if you don't know what that means, that's okay. I'm going to attempt to summarize and see if Dr. Bright agrees. If you test for this and you come back positive, you have the disease. We feel like there's very good specificity. If you test and you come back negative, it does not necessarily rule it out. It decreases the chances you have it, but it doesn't rule out the disease. Would you agree with that very simple statement?
Correct.
All right, so a massive hedge by Dr. Bright, but I get it. He's a scientist. He's going to give us the data and stick to the data. Dr. Bright, is there one test or multiple tests here? People talk about the SARS-CoV-2 test. What does that mean?
So in the U.S., the FDA has approved the Center for Disease Control's specific SARS-CoV-2 COVID-19 diagnostic test. It's a quantitative PCR test. So in the U.S., there is that one test. The WHO, the World Health Organization, recognizes 7 tests around the world. So there's the tests here in the U.S., France, Germany, China, Japan, Hong Kong, and Thailand all have tests that have been deployed on a decent scale and that the World Health Organization recognizes as valid tests. All the tests are very similar in the way that they attempt to find the virus, which is by looking for the viral RNA, the nucleic acid that is present with the virus. They differ in which parts of the viral genome they actually look for. So in the U.S., we look for 2 parts of the viral genome. In Japan, they look for 3 other parts. And that's just a function of the way that each of those public health agencies design their tests. So in the U.S., there is one test that we are basing on, which we're calling the CDC gold standard test.
So multiple tests that exist and are probably good, but one that is FDA approved in the United States. Is that a correct summary?
Correct.
Why is there a shortage? What's the problem?
So the issues are many. Most of them are on the bureaucratic side. Very few of them are on the clinical side. So when they first started getting the test up and running, they applied for emergency use authorization, EUA, from the FDA. This process, in theory, could have taken 1 or 2 days. In this case, it took weeks. That just delayed everything moving forward. Initially, the first attempt at the test by the CDC did not have the appropriate specificity. We were talking about a couple minutes ago. From a scientific standpoint, not unexpected. This is a dynamic situation of a novel virus. It's not unexpected that the first attempt would not be, a home run. But again, that delayed us as well. Moving forward, the test is not what they call a sample to answer test. Many of the clinical labs around the country, especially the more numerous ones, are able to take a patient sample, place it in a machine, hit the go button, and get an answer. So sample answer tests are very easy and they're easy to scale. This is a high complexity test. You have to actually run a quantitative PCR assay, which requires specialized equipment, specialized reagents, and specialized training. So getting all of that equipment spun up has taken some time as well. Another thing that has delayed us is the need for actually transporting the samples. So you're getting what they call the viral transport media. So after you take that swab we were talking about, you have to place it in a particular media to ship it to the testing facility so that it preserves the sample. It has taken that has been shown to be in short supply, and we're just getting that scaled up from those manufacturers as well. So, there's been some bureaucratic issues. The sheer scale of what we're looking at here has put some strains on the system that is not definitely not designed for this much testing. And then the fact that the test is quite complex and getting all these new specialized pieces of equipment around the country has also taken some time. So the public health agencies are doing the best they can. It is taking a little more time than expected, but we're starting to see things shake out.
So when you and I started talking about this last week, it became apparent to me that you actually understood the problem and why there was an issue here. And we are not going to place any blame. We are never going to get political. There's no time for that kind of thing. There's plenty of work to be done, so that's what we're doing. So when we talked, it seemed you had a good understanding of the problem, and therefore I asked you, well, do you have a solution? So my next question for you is, what can we do? And then we're going to talk about what we are doing and what others can do as well. So what can we do right now, Dr. Bright?
So to directly address the problems that I just laid out, which is the relative dearth of the specialized equipment and specialized training, we have access to that equipment, and we have the expertise within myself and the clinical testing team here to spin this test up, and we are actively working to get the CDC gold standard test online in our laboratory. So that's directly what we're doing to add capacity to the system, so that we can help be part of the solution to what is now a global public health situation. We're additionally doing two other testing protocols in parallel. One, we're bringing on a rapid diagnostic screening test. This will help push through very quickly individuals who may have a coronavirus-like disease, which would then be indicative of moving on towards working in the CDC gold standard test. So where this would be very interesting is that we're trying not to overwhelm the healthcare system here. So if you have a flu, which is also its own medical issue, we want to know that more quickly than if you have a coronavirus. So that kind of rapid, quick point of care diagnostic is going to be very important to bring. So we're bringing that capacity online as well. We have the CDC gold standard diagnostic that we're bringing online. And then additionally, I'm leading some more advanced whole genome sequencing of the viral particles, looking for better indication of a better way to test, essentially. So what do we know about this virus? How is it mutating? Are there different ways that we can look for the viral genome that are less variable, i.e. increasing specificity you said is high, but getting that sensitivity up? So those are the three ways we're doing. So rapid diagnostic screening, bringing on the CDC gold standard to add capacity for the system, and then continuing our own research to help better understand this virus and hopefully create better diagnostics in the long term.
Yeah, it became clear to me when we were talking last week about the issues here. It seemed that the real hurdle when we really dug in, we spent some time on this, was not expertise, not equipment, maybe not even supplies, but we're not 100% sure about that. But the issue for us, at least, was capital. I realized that we actually could do something, and the main hurdle was just the finances. And to me, that was an unacceptable hurdle. So we have kind of gone out on a limb, and we've talked to Dr. Bright and said, don't think about capital or money, just help, just get something done. So that's what we're doing. We're taking multiple parallel tracks. Like Dr. Bright said, we're going to be trying to roll out the CDC approved test very soon, as quickly as we can. We think maybe within 2 weeks we'll be able to do that. I hate to throw I think I may get some cringing from Dr. Bright, but those are the numbers that he kind of gave me as best estimates. We also just today, in the last hour, we are trying to order a point of care machine that may be able to turn around results in less than 30 minutes, and they are in the process of FDA approval for that as well. If not FDA approved, we still think it's probably a good test we're evaluating, and we may try to be a research facility for that to be able to offer that test even before it's FDA approved within the next couple of weeks. So we're taking parallel paths. And what are the odds that the CDC and other organizations or private labs solve this before we do? Extremely high. But to us, it's not worth the chance, and we want that insurance. We want to do anything we can. So speaking of that, what could others do as well to help in this situation, Dr. Bright?
Others, I guess, in which groups? Clinicians, patients, other labs?
Really anyone. I think a lot of people out there are thinking, especially labs, if they have equipment or just private individuals, is there anything anybody else can do? And if the answer is nothing really, that's totally fine as well. But I know people are thinking that. People are thinking about protecting themselves, protecting their families, but also, what can I do? A lot of people want to help. Is there anything that others can do? Any suggestions?
So, I mean, on a couple different levels, I mean, the people who can most immediately assist are individuals with some sort of access to or coordination with some sort of laboratory. So whether that be an academic laboratory or a private laboratory, these or even a veterinary diagnostic based laboratory, this equipment is out there, and it's just bringing it online to add capacity to the system. So again, we are looking at this ourselves as a private laboratory. Heretofore, it's mainly been done by our public health agencies and public health laboratories, but we need more capacity in the system. So whether you are directly related or tangentially related to any sort of laboratory, bringing that on is always of useful. From the patient perspective, be very aware of current recommendations, and then obviously work very closely with your health providers as to when testing is most necessary. That will help reduce burden on the system as we're looking to test those patients most indicated as we're bringing up capacity. And again, this is a decision chatting with your medical provider. The two of you are most able to make that decision.
So who to test and when to test is going to be an evolving issue, because if there are capacity issues, then you only want to test higher risk individuals potentially. But as capacity increases, the testing recommendations may change, because we may want to do more screening, identify those people who may be spreading asymptomatically. So look for the guidelines. The guidelines are going to be changing. And so as to what to do, when to get tested, trust the major guidelines. If you're one of our patients, ask us, and we're changing our protocols frequently based on our capacity and what's going on as well. Taylor, what is the equipment, supplies, et cetera, that is needed right now? Nothing that we do at Wild Health is going to be really proprietary. We just want to share and help with this problem. So what are we doing exactly? What equipment is out there? What kind of supplies and things?
So the one nice thing about what's gone on with the CDC as well as the other World Health Organization recognized tests is that everyone in the global public health community is being very transparent here. All of the reagents, all of the, what are they called, the primers and probes, those pieces of the assay that are specific for looking for the viral nucleic acid are all publicly available, and you can all find those. So we're very much following the set guidelines. We are bringing on quantitative PCR machines. We're using the Quant Studio from Fisher, but there are many ones out there from Applied Biosystems. Many different machines out there that can do this. And those again, freely available primers and probes, which make the base of the test, are you can order those from wherever, or labs can order those from whoever their favorite vendor is and get that up and running. Where we're really going to see a strain on the system is looking at our reagent providers, because there are a few different pieces, whether it's isolating the viral nucleic acid or amplifying the viral nucleic acid, which are going to be real strains on the system. So today there was a move by the federal government to give more grants to those reagent providers, which is going to be very necessary. We are actually working very closely with our academic colleagues. They have a lot of these reagents on hand that they do for basic research, and they're obviously freely making those available to anyone doing this type of testing, whether an academic medical center or us as a private lab. So the collaboration that we're seeing from all of our research colleagues across the different, whether that be industry or clinical or academic systems, has been very nice to see, and we're hoping that will continue.
So if you have questions, send them to @WildHealthMD. We're going to get Taylor back on the podcast to answer those questions. I don't want to steal very much of Dr. Bright's time, just because it's very valuable right now as we try to spin these tests up. If you're not one of our patients, follow the guidelines, talk to your physician, look at the CDC guidelines. If you are one of our patients, contact us. Our goal is to take cost out of the equation. So if you feel like you need to be tested, talk to us, and we will talk to you about whether to get tested or not based on all of the factors involved, capacity, everything that we know, and it's going to be changing day by day. So tune in to the next podcast. We'll have more updates for you. Send us your questions. And anything else you think people need to know, Dr. Bright, right now?
Not right now. I mean, as I mentioned in the beginning, this is an extremely dynamic situation. Like just this morning, the CDC test underwent a fairly material revision that is going to impact the way that we run the test in a positive way. We're going to be able to run more tests through the system, but it's changing all the time, and especially as capacity increases, as Dr. Dawson said, the ability to test more people is really what we want. We want to do that screening function so we can see what's out there. So just be very cognizant of what's going on, and take care of yourself and take care of each other.
Thanks, Taylor. Now get back to work. We really appreciate the work you're doing. Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help.